Good afternoon, everyone, and welcome to today's Rounds presentation on guidelines for testing and treating long COVID. My name is Dr. Reid Morrison. I am a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. Thank you in advance to our presenters for providing a land acknowledgement during their presentation. I will note that I am joining from the traditional territory of the Anishinaabe Algonquin people. As the Algonquin people have inhabited and cared for these lands since time immemorial, I would like to take a moment to express my gratitude and respect to them and to the land for all that it has provided and will continue to provide. It's now my pleasure to introduce our speakers for today's presentation, Dr. Kieran Quinn and Dr. Emilia Liana Falcone. Dr. Kieran Quinn is a general internist and palliative care clinician scientist at Sinai Health and the University of Toronto. His research focuses on improving access to high quality end-of-life care for people with non-cancer illnesses and those living with post-COVID-19 condition, or PCC for short. He co-chairs Canada's clinical practice guidelines for treating PCC and has co-led the creation of the National Long COVID Research Network. Dr. Emilia Liana Falcone is the director of the post-COVID-19 research clinic at l'Institut de Recherche Clinique de Montréal. She studies the role of the microbiome in post-infectious conditions and leads research on long COVID. Dr. Falcone co-chairs Canada's clinical practice guidelines for the testing and diagnosis of PCC and serves as an expert on national advisory groups. Welcome to both of our speakers, and thank you very much for being with us today. I will now pass it over to Dr. Falcone to begin the presentation.
Thank you very much, Dr. Morrison. All right, so thank you for this introduction. Here is our Public Health Ontario disclaimers. So here are our disclosures. Sorry, skipped a slide there. I'd just like to also point out that I recently filed a patent for involving the treatment and diagnosis of long COVID, but none of the content is at all related to the content presented today. So we've heard a land acknowledgement. This is the one for the CAN PCC initiative. So the work of CAN PCC has taken place in Canada, the traditional, ancestral, and unceded territory of many Indigenous nations. We honor the rich cultural and traditional practices, languages, and histories of Indigenous communities across Turtle Island. We pay our respect to the First Nations, Inuit, and Métis people of this place who have stewarded this land for millennia. All right, so here are our objectives for today. So by the end of this session, participants will be able to describe the impact of post-COVID-19 condition, or PCC, and the methods used to develop the guidelines. They will describe the recommendations for testing, identification, diagnosis, and clinical interventions for PCC. They will discuss how the recommendations can be integrated into practice and identify key resources for dissemination and strategies for implementing PCC recommendations. And I will now pass it on to Dr. Quinn.
Dr. Falcone, thank you so much, and welcome everyone. Thank you again for taking time out of your busy days to join us. It's been such a pleasure to work with Dr. Falcone, and I can confidently say now Liana has become a friend over the last few years together and a place for me to stay when I visit Montreal, which is where I went to McGill for my bachelor's degree. But back to the presentation at hand, post-COVID condition, also commonly called long COVID, it's relatively new. We have to remember that this is a new diagnosis, a new disease that has only emerged in the last 5 years. And it's a very complex condition. It affects pretty much any organ system in the body and manifests itself in many different ways in different individuals, including across a spectrum of severity and time. When it comes to the definition, actually it's quite variable across the world, and there are new definitions continuing to be published and evolved. But we at CAN PCC adopted the WHO clinical consensus definition, and many other jurisdictions have used the same. And this definition focuses on persistent symptoms that develop within 3 months from an acute SARS-CoV-2 or COVID-19 infection, and the duration of those symptoms lasts at least 2 months. Remembering that those symptoms can come and go, can change different organ systems, and have a level of severity that may or may not impact somebody's daily life. The estimates for how many people are affected by long COVID are quite difficult to truly estimate, especially when you lack a consensus definition across the world. Still, the best estimates that we have are that approaching 500 million people are estimated to have post-COVID condition or long COVID. Looking inside Canada, we see that, looking inside Canada, we see that this condition affects approximately 1 in 9 adults, or 3.5 million Canadian adults have reported long-term persistent symptoms after a COVID-19 infection. This data comes from StatsCan and the Public Health Agency of Canada surveys that they completed their second phase in 2023 in the summer. The other important impact is to think of beyond just our health, but our economic and functional abilities. And more than 500 million Canadian adults are affected such that they are missing days of work and school. So these are broad-ranging and significant impacts. As I mentioned, it's a multi-system disease. There have been more than 200 symptoms characterized, but the most common ones are fatigue, and there are very specific and disabling types of fatigue that we'll talk about a little bit later in the recommendations. And they span to things like experiencing pain, shortness of breath, cognitive dysfunction, or some people will call that brain fog, insomnia and sleep problems. And post-exertional malaise is this specific type of fatigue whereby even with minimal physical or cognitive activities, people can experience a crash that really wipes them out. Their battery is no longer charged. And that can last for 2 to 3 days or sometimes a couple of weeks in some cases. And really, we hear from our patients and our people with lived experience on our guidelines that perhaps this is the most disabling and impairing symptom that people will suffer with. When it comes to how we're doing as a healthcare system, surveys across our country demonstrate that only 1 in 8 adults who looked for help to get support for their symptoms really felt that they received appropriate care. And we hear a lot about experiences of patients feeling dismissed by their healthcare providers or not getting the type of care that they think they need. Now, I wanted to complete our third poll of today. And for those of you who are health professionals and clinicians out there, what proportion of the people that you look after in your practice experience long COVID? And this is just a rough estimate, and I'll ask that we have the poll up now. And so we're looking really across 4 categories. And again, just your best guess. Either you don't look after people with long COVID at all, and that may be the case, or you have a minority, a sort of moderate level, or a majority of your practice may in fact be focused on the care of people with long COVID. So if you could just take a moment to choose one of those 4 categories, we'll be able to display the results in just a few minutes. Recognizing we have a very diverse group of individuals with us today, some of whom may not actually be involved in the care of people with post-COVID condition, and some of them may actually be living with post-COVID, or both. So we'll just give it another second. And the majority of you responded that you do not look after people with long COVID, but we do see a significant number of people who also have a minority practice or even approaching a majority practice where the patients that you look after or the clients you look after have long COVID. So I'll just go to the next slide here and close that poll. And this is from a quote from Dr. Mona Niemer, who's our chief science advisor. And really what came out of the work we did with her and her team at the National Task Force is really to highlight that there are significant evidence-based and knowledge gaps that really impair our ability as clinicians to help people and look after them. And we really need to focus on more investment and support for people with PCC. I'm going to turn it now back over to Dr. Falcone to carry on with some of the slides. My apologies, sorry. We made some last minute changes to the slides and I got myself mixed up here. I'm going to keep going and just take you through a few more slides here, looking at some of the methods that we work as a large interdisciplinary team, including people with lived experience. So this CAN-PCC initiative is a combination of McMaster University and many researchers and clinicians there with Cochrane Canada, who is experts in evidence synthesis and being able to find the existing evidence out there and the steps that we go through to evaluate that evidence and apply it to people with CAN-PCC. My computer here is just not advancing the slide. Let's see if we can get going here. Try again. There we go. Oop, there we have a delay. So I'm going to skip that last slide. It's pretty text heavy. But what we're going to talk about here is really the makeup of our project groups. And it's, as you can see from this busy slide, it's actually a very broad and diverse group of individuals. So we have an executive oversight committee that really oversees the entire work and ensures that it's done with the utmost quality and rigor. And on the top right there, you see we actually have an international advisory board. So people who are bringing the perspectives beyond Canada and experts from around the world in long COVID who can help inform our work and ensure that what we're doing makes sense and is rigorous. Within our teams, we have evidence synthesis teams, as I mentioned, through Cochrane. We have 6 guideline teams that are focused on individual components. Dr. Falcone looks after testing. I looked after pharmacological and non-pharmacological treatments, and there are 4 other teams. We have an oversight guideline development group there that reviews and audits everything that we do to make sure it's of the highest quality. And once we've made these recommendations, now we have a complete separate knowledge mobilization committee, who's really working on things like today to help get the message out there and help patients and practitioners know what's available and what the evidence says. The other people I really, really want to highlight, and I think these are a must-have for any guideline committee moving forward, are a public member panel. So it's really important to get the public's input, not just our clinicians and policymakers. And we also have a dedicated equity oversight committee. And that committee really ensured that equity was always at the forefront of our work and that it was not an afterthought, but actually a primary place to start when we're picking the priority topics and addressing the evidence and how it may impact equity across our healthcare system. Hopefully the slide will move forward here. And so that just, this slide just again reviews the Equity Oversight Committee, but what I wanted to highlight on the bottom right in that text is that committee helped us identify a group of priority seeking individuals, and those include Indigenous individuals or Indigenous peoples, refugees and migrants, 2SLGBTQIA+ individuals, older adults, women, pregnant women, racialized groups, people experiencing homeless and justice-involved people. And so everything we did, we tried to look across all equity domains, but really with a specific focus on those priority-seeking groups. And just to let you know who we are as CAN-PCC, it's not just Dr. Falcone and I. It is a group, a very broad and diverse group of everyone who touches the healthcare system, including all sorts of healthcare professionals, many, many, many dedicated people with lived experience and their caregivers, several policymakers, health economists, and really a huge team of experts that have a specialty in guideline development and all the pieces that go into this enormous undertaking. And I really just wanted to take a moment to highlight the core members of our team who are people with lived experience, who you can see here in their pictures. And they really have experienced a broad spectrum of severity of illness and experiences in the healthcare system, and played integral roles right from the very beginning of this work to help ensure that the voices of the people that are most important to be heard were present as partners on our teams. And Kimberly, who's one of our dedicated persons with lived experience, provides this nice quote, which I'll just read for you without trying to paraphrase. So she says, as a person with post-COVID condition, I would like to see clinicians consider these guidelines in their practice. I would like to encourage sensitivity when patients are expressing those concerns. And I would like to see the public use the guidelines to best inform and empower themselves in their health decisions. I wanted you to understand a little bit more, without going into too great detail, how we actually make recommendations, because it's not just simply looking at a magnitude of effect for the evidence when it comes to a treatment. There's many, many, many different considerations that are thought about and taken into the teams. So first and foremost, we needed to identify what are the really important questions. There's only a certain scope and limited number of resources we have to be able to address this. And so we wanted to hear from our government and policymakers, most importantly from people with lived experience in our public, and important healthcare organizations. And through a very lengthy process, we identified priority questions across all of the 6 teams. We then asked our evidence synthesis teams to scour under every rock and corner to find any bit of evidence that might be relevant to those questions. And we go through them in great detail on our teams to interpret and discuss and critically analyze whether the evidence is relevant to our questions at hand, and if so, what are our consensus decisions around the recommendations as far as, in our case, specific treatments, or Dr. Falcone's team, specific testing that should or should not be done. Once those recommendations are made, we circulate them to the public for comments to ensure that what we're doing is still useful to those who are in most need. We bring it back, we revise and review those comments to integrate them into our work, and ultimately the teams and then the guideline development group approves those recommendations. And here we are today trying to disseminate that knowledge. These are the 6 different teams that I've been mentioning, and to date we've released 99 recommendations on the website that was provided in the chat. And those 6 teams are looking at prevention of post-COVID condition. Dr. Falcone's team, as I mentioned, looks at testing, identification, and diagnosis. My team was then looking at the pharmacological and non-pharmacological treatments or clinical interventions. We have a team dedicated to neurological and psychiatric topics. We have an entire team dedicated to pediatric, adolescents, and youth, and a team that looks at the healthcare system and its services, along with important social supports, and making series of recommendations. And I'll say we have 13 more recommendations that are just finalized and being released in June. So please do keep an eye out for that. This is probably one of the most important slides when it comes to our knowledge mobilization efforts to help people understand the language of a recommendation. So any particular recommendation we make comes with a strength and a direction. The direction is quite simple. It's whether for or against, or in some cases there are some specific nuances around in a context of a research setting. That's pretty straightforward. But the strength, I think, is where people sometimes struggle, especially with how to apply these recommendations. So a strong recommendation is such that we have very high certainty that the evidence is giving us the actual truth, and we strongly recommend, in other words, people probably should follow those recommendations for those specific conditions. Most of our recommendations, as you'll see, are actually conditional or weak recommendations, which mean that we have little confidence or certainty that those will result in the effects that we believe will come from them. And so it means that a very careful discussion should be had between a clinician and a person who is facing those treatment decisions about whether that is the right treatment for them. And if there is a recommendation against, it does not mean do not use. It means probably you shouldn't use, but if you wish to use, do so with caution and have that very careful discussion so you're fully informed when you're trialing these different treatments or tests or other recommendations. And they're, again, just giving you a little bit of all of these different domains that we go through when we're making these recommendations and reviewing the evidence. It takes into population level perspectives on the benefits, the certainty of our evidence, but other really important and practical considerations like what is the cost to our society and who is paying for that? That's going to impact people and payers' acceptabilities. Are people willing to try these treatments or recommendations? And are there different levels that may view those with varying acceptability? What is the feasibility of implementing these recommendations? In some cases, it might be very easy. In other cases, nearly impossible. And that really plays into whether we're weighing things on a for or against basis. There's always a risk of harm, and as physicians and clinicians, we never want to cause harm to our patients. And equity is always there as a separate and independent and important domain, as well as how people may have variable values and how they would prioritize certain benefits or certain harms over other people. So all of this is taken into account when we're making our recommendations. And I'll just reiterate that the certainty of evidence is really founded on the quality. So a really well done randomized double-blind trial in the population of interest is going to be much more certain and a much higher quality than an observational study that doesn't even study people with PCC, but maybe a related condition. And we issue those conditional recommendations rather than a strong recommendation when we see not a lot of difference between the benefits and harms, when the quality of the evidence can be quite low, when the values and preferences of individuals for those benefits and harms might vary significantly. And as I said, the end result is that most people would probably want to follow the recommendation when it's conditional, but we must recognize that many would not, and we need to leave that flexibility for those discussions in practice. I'm going to turn it back now over to Dr. Falcone, who's going to take you through her team's work on testing recommendations.
Thank you so much, Dr. Quinn. You really made my job easier by giving us all the essential information to help us better discuss the recommendations that are going to be presented today. So, as mentioned, I'll be talking about our testing recommendations. There's going to be a total of 15 recommendations published. Today, we are discussing 9. And as many of you likely know, we are lacking tests to specifically diagnose PCC. Nevertheless, there are plenty of tests that may or may not be useful in the evaluation of individuals with suspected PCC. And so to help us better appreciate or analyze the potential benefits of specific tests, we did establish a framework, which I'd like you to be aware of, because it'll help you maybe look at these recommendations with a different optic. So in addition to looking at the evidence, we asked ourselves whether the test increases our suspicion of PCC. We also asked if the test can help diagnose comorbidities that may or may not be associated with PCC. And finally, we asked if the test may lead to a change in management. Okay. Oh, not sure where we're going backwards, but I will go forward. Okay, so now for our first recommendation. Should ECGs be used for people with suspected PCC who have respiratory or cardiac complaints? And so the CAN PCC collaborative did suggest the use of ECGs versus not using ECGs in adult patients with suspected PCC and cardiac or pulmonary symptoms. Here, the benefit being that the test can help diagnose important comorbidities, for example, myocardial infarction, an arrhythmia, maybe evidence of pericarditis, but not increasing specifically suspicion of PCC or making a diagnosis of PCC. This was a conditional recommendation based on very low certainty of evidence. And here is our evidence to decision table. And what I'd like to point out is even though you see that the benefits and the harms were both judged as being small, the balance of effect still probably favored the ECG because the panel felt that missing a potential or making a potential serious diagnosis of an important comorbidity, like, for example, a myocardial infarction, would be very serious, very important, and that is what tilted the balance of effects. Our next recommendation, which is a little bit of a continuation from the ECG, is whether a Holter monitor, and here we're talking about a 24-hour Holter monitor, be used for people with suspected PCC who have respiratory or cardiac complaints. And here the idea was that this could help us diagnose an arrhythmia. We know that there is an increased risk of cardiovascular complications after COVID-19 infection, and hence the importance of this test. And so the CAN PCC collaborative did suggest using Holter monitoring versus not using Holter monitoring in adults with suspected PCC and certain cardiopulmonary symptoms. And specifically, we mean chest pain, shortness of breath, palpitations, tachycardia or bradycardia, which could be sustained, intermittent, or of short duration. And so again, this was another conditional recommendation based on very low certainty of evidence. And here is the evidence to decision table. And again, the balance of effect probably favored the Holter test for the same reasons, because of the importance of not missing or diagnosing a serious comorbidity like a cardiac arrhythmia. So the next test evaluated was the 10-minute stand test. And this one is particularly important and raised a lot of discussion because it can help diagnose cardiac dysautonomia. And in particularly, what we can see a lot of is postural orthostatic tachycardia syndrome, or POTS. And this is a condition that is actually highly associated with PCC. And so after evaluating the evidence, the CAN PCC collaborative did suggest using the 10-minute stand test versus not using it in adults with suspected PCC and dizziness. And here the benefits were, yes, to increase suspicion of PCC by diagnosing cardiac dysautonomia potentially, and also diagnosing or ruling out important comorbidities, but again, not making a diagnosis of PCC. And here is our evidence to decision table, and you can see that here the balance of effect probably also favored the 10-minute stand test, as the benefits were moderate, whereas the harms were trivial. The next test was, should troponin be used for adults with suspected PCC who have respiratory or cardiac complaints? So this is a test. It can help diagnose a myocardial infarction. Sometimes it can be raised in other conditions like myocarditis. And the CAN PCC collaborative did suggest the use of troponin, or the high sensitivity troponin eye test, in adults with suspected PCC and cardiac or pulmonary symptoms. Again, the role here being to rule out or help diagnose a serious comorbidity, or even assessing prognosis and monitoring evolution over time. And again, the cardiac or respiratory symptoms to be considered were chest pain, which can also include referred pain from another part of the body, such as the neck or the shoulders, as well as palpitations and shortness of breath. Again, this is a conditional recommendation based on very low certainty of evidence. And here is our evidence to decision table. And again, despite both the benefits and harms being judged as small, the balance of effect probably favored the intervention or the test, because of the importance of ruling in or ruling out a serious comorbidity. So the next test was, should a C-reactive protein, or CRP, be used for adults with suspected PCC? This was a little bit controversial, which is why we are discussing it today. So the CAN-PCC collaborative suggested not using the C-reactive protein. And this was a conditional recommendation based on very low certainty of evidence. However, the discussion was largely based on the utility of the test on its own versus if it's done in parallel with other tests that would be, in fact, diagnostic of a comorbidity that may or may not be associated with PCC. So we want to point out that this recommendation, it does not mean withholding care or diagnostic testing that could be clinically appropriate. For example, especially in the context of PCC, it could be a useful add-on or parallel test when assessing individuals who have a diagnosis or may be suspected of having autoimmune conditions, or who are being evaluated, for example, for pericarditis. And this is our evidence to decision table. So the next test was whether questionnaires should be used for post-exertional malaise or post-exertional symptom exacerbation, and screening using these questionnaires in adults with suspected PCC. So as Dr. Quinn alluded to earlier on when discussing the symptoms associated with PCC, one of the complications is that patients can have post-exertional malaise or post-exertional symptom exacerbations after efforts that can be physical, mental, or after emotional stress. This is highly associated with PCC, so it's a very important condition to evaluate. And after evaluating the evidence, and here I'll say the evidence was largely based on one questionnaire. It is the DePaul Symptom Questionnaire Post-Exertional Malaise short form. So there are lots of DePaul symptom questionnaires, but it was this specific one for which we had the most evidence, and not to be confused also with the DSQ short form. So it's the DSQ PEM short form. And the CAN-PCC collaborative did suggest using the questionnaires to screen for post-exertional malaise versus not using them. And the real benefit here is increasing suspicion of PCC and diagnosing a condition highly associated with PCC that could inevitably lead to a change in management. All right, and here is the evidence to the, oh, sorry, we went back one. Let's go back. There's our evidence to decision table, and you can see the benefits were moderate, the harms were judged as being trivial, and so the balance of effect probably favors the test, which is using PEM questionnaires. Okay. All right, and along those same lines, we had a question about using tools to assess functional status and quality of life. And here specifically, the tool to assess functional status was the post-COVID-19 functional status scale. That is where we had the most evidence. And to assess quality of life, we used the EuroQoL 5D or EQ5D, also because we had the most evidence using this score. And the question is whether we should use these tools to assess adults with suspected PCC who have fatigue or dizziness. So there's like a subgroup within the population here. And the CAN-PCC collaborative did suggest the use of these tools to evaluate adults with suspected PCC and dizziness and or fatigue. And again, the value here is that they can increase suspicion of PCC as well as help diagnose important complications, such as chronic fatigue syndrome, for example, and can be used really as helpful assessments to evaluate the impact on quality of life and on functional status. But again, it does not help us make a diagnosis of PCC. And here's our evidence to decision table. And similar to the previous question, our benefits were judged as moderates, whereas the harms trivial, therefore tilting the balance of effects in favor of the intervention. The next question, we're getting into more of our respiratory evaluations, is should a chest X-ray be used for adults with suspected PCC who have respiratory or cardiac complaints? So here, the main thing to point out, so it's obvious that an X-ray could help us diagnose a pulmonary comorbidity, of pneumonia. There could even be evidence maybe of heart failure and other complications. However, the data that was available was purely evaluating patients who were hospitalized during the acute phase of their infection. So based on the available evidence, the pretest probability was likely to be higher in individuals who were hospitalized in the acute phase of their infection. And we were not able to evaluate the pretest probability in people who are not hospitalized in their acute infection due to this lack of evidence. But again, we therefore think it's more likely that this test will be revealing in the specific population that was hospitalized. But further studies are needed to know what happens in the non-hospitalized population. And this is our evidence to decision table. Again, the benefits and harms were both judged as small. And so here there is a variability in the balance of effect, largely driven by whether or not the patients were hospitalized in the acute phase of their infection. And finally, this is our last recommendation discussed today, is should a CT scan of the chest be used in adults with suspected PCC who have respiratory complaints? So here we issued 2 recommendations, okay? And the recommendation, the decision to have 2 recommendations is really based on the risk of individuals having pulmonary complications. So the patients who are considered to be at a low risk of having pulmonary complications are those without any of the following: current respiratory symptoms, previously identified important abnormalities on either chest X-ray or CT chest or pulmonary function tests, patients who were previously hospitalized during the acute phase of their COVID-19 infections, and patients with a high clinical suspicion for pulmonary disease. So for those who were at low risk of pulmonary complications, so they did not have any of these risk factors specifically mentioned, the CAN-PCC collaborative suggests not using non-contrast CT chest scans. However, in individuals who or adults with suspected PCC and respiratory symptoms who were considered to be at high risk of pulmonary complications, the CAN-PCC collaborative does suggest using a non-contrast chest CT. And again, here the benefits are diagnosing or ruling out important conditions, but not making a diagnosis of PCC. And this is our evidence to decision table. And the variability that is observed is really, especially with regards to the benefits, has to do with their risk of having pulmonary complications. And the same thing with respect to variability related to feasibility. This will have to do with access to the test, which may be limited in remote communities or resource-limited settings. All right, and with that, I will pass it on to Dr. Quinn, who will speak about clinical intervention recommendations.
Thanks, Dr. Falcone. So in just keeping an eye on the time, I'm going to move through these briefly as well, and we're going to go through 6 of our recommendations, recognizing that there are many, both on the pharmacological and non-pharmacological side. So this one really looks at, I think, a very important intervention, and one that I get asked as a clinician about a lot. Should activity, movement, or exercise-based interventions be used in people with PCC? And what we did as a team was split that into people who do and who do not experience post-exertional malaise or post-exertional symptom exacerbation. And the reason is because often this type of physical activity can trigger these events. And so there's probably a differential risk of benefits and risk of harms according to those 2 separate groups. So for people who do not experience either PEM or PESE, we, as a CanPC collaborative, recommend for using activity, movement, or exercise-based interventions. And I think it's really important just to flesh out that exercise can be a part of rehabilitation, but rehabilitation is not just about exercise. And these interventions need to be individually tailored and are often multiple components that really need to take into account a person's dynamic symptoms and their energy budget. And we now have a screening tool recommended by Dr. Falcone's team on how to identify that, and it's recommended that we look for it. Sorry, the slides, Zoom will screw you every time you try to use it, so I'm having a little hard time here advancing the slides. Maybe capacity building can help me with that. So this is the recommendation on those types of interventions for people who do experience PEM and PESE. And the recommendation here is that because of the risk of harm and concern around those types of interventions in people who do experience PEM, PESE, we are recommending that this should be very carefully considered and not brought into clinical practice yet. That, in other words, we should be studying these types of interventions in people with PEM, PESE in research settings only, like clinical trials. Moving on to the evidence to decision tables. So in people who do experience PEM, PESE, there were benefits. In people who do not, there are lots of benefits: reductions in fatigue, improvements in physical function and physical activity, with very little risk of adverse events. In fact, we saw less adverse events in people who were doing activity-based interventions than people who were not in the evidence. When you look at the evidence for people who do experience PEM or PESE, there are benefits that are measured in those studies. However, when those studies were done, most of them do not screen or even try to measure PEM or PESE, which often occurs after the activity session. So because of that, there was a lot of uncertainty and a lot of significant concerns around harms. And for that reason, we ended up making the recommendation for research settings only. Now, the use of metformin and the antiviral Paxlovid, I can never pronounce it, nirmatrelvir and ritonavir are quite common and was discussed a lot throughout the pandemic. So we were able to look at those two separately and try to make a recommendation about them in terms of their priority of one over the other. So what we recommend among people who have post-COVID condition and then experience a new COVID-19 infection, which is common in the current day, we actually recommend that people take metformin over Paxlovid, and this will help prevent worsening or new post-COVID symptoms that people are already experiencing. Now, what we could not do was make an evaluation of the evidence for a combination and whether you should use that combination. So that is just an important caveat to know. Here's the evidence to decision table for metformin. There were lots of benefits noted. Metformin is an old drug. It's quite safe in most people. It's cheap and readily accessible, and so that was why metformin was preferred over Paxlovid, which also had benefits, but also the presence of some harms. There are known adverse effects, and it is a lot more expensive than metformin, and there are significant feasibility and equity factors when considering that. So what we do when we're trying to make a priority recommendation over one or the other, we do this thing called the multiple intervention comparison. We look across the 6 domains that we use to make any judgment, and then we compare them. And the more stars you get in this, the better. And so we see that the balance of effects between the two drugs are actually quite similar, but metformin is so much cheaper, and so it gets 4 stars and Paxlovid only gets 1. And you can see the remaining stars, but at the end of the day, if you were to tally up all the stars, metformin comes out as the winner, and which is why we recommend it over Paxlovid during a new infection. Dr. Falcone talked a bit about POTS and the treatment of that. There are guidelines from our Canadian National Cardiovascular Society around the treatment of this condition, which is common in people with PCC. And we evaluated 4 different drugs, ivabradine and beta blockers, both which work to slow the heart rate down. Pyridostigmine and midodrine work to increase blood pressure and help reduce the dizziness and orthostatic symptoms. And in the end, the CAN-PCC made a recommendation to use these medications as appropriate. And what we mean by that is if you have a POTS variant that is elevated heart rates, whether you're tachycardia or inappropriate sinus tachycardia, you're going to be using drugs like ivabradine and beta blockers versus an orthostatic predominant POTS where you're going to be using pyridostigmine or midodrine. And here's our evidence to decision table that evaluated the sum total of that evidence. And it's a bit too nuanced here to break down each one, but suffice to say, we evaluated them all independently to come up with a final recommendation. This idea of microclotting and also macroclotting, like venous thromboembolism, is quite a major discussion in people with PCC and post-infection. And so one of the priority questions was whether we should be using antiplatelet drugs like aspirin, Plavix, or clopidogrel, ticagrelor, or other antiplatelet agents to help prevent some of these downstream consequences. And in the end, we actually recommend against the use of these routinely in people with post-COVID condition because of the risk of harm. And if you look on the evidence decision table, there are really very trivial benefits in the use of these and very real bleeding risks, which are known with these drugs. And some of them can actually be quite expensive as well. So first, do no harm is our principle. Lastly, a drug that's received a lot of attention in the lay press and in our communities, low-dose naltrexone. Naltrexone is a pain medication usually used in much higher doses, but in low dose is felt to have some other types of effects on the body and may modulate pain and immune system responses. And when we looked at the evidence for low-dose naltrexone, there really was no signal for benefit, and ultimately the panel made a recommendation against its use. Here is the evidence to decision table for low-dose naltrexone, if I can get it to come up. And really it was these contextual factors around the variable acceptability, the fact that many pharmacies and jurisdictions and provinces and territories actually don't even make this or have it on formulary, so it has to be done at a specialized compounding pharmacy. That has major impacts on equity and accessibility. So we'll just try to wrap it up now in the next couple of minutes. I'm going to turn it back over to Dr. Falcone to take us through the last couple of slides, and we'll still have some time for questions.
Thank you so much, Dr. Quinn. So I'd like to point out, it'll be a little bit quick out of the interest of time, but there are several resources available to you to go deeper into the subject and get into the details of these guidelines and recommendations. So there's the recommendations map, or the rec map, available on the CAN-PCC website, which is a very cool way to navigate according to different subgroups or symptomatologies. There are the plain language recommendations, which summarize the recommendations with user-friendly language in a one-page view. There's also several resources for patients, including interactive infographics and online resource sheets and webinars. And this is what the online resource sheets and interactive infographics look like, for example, for the testing recommendations. And this is what they look like for the clinical intervention recommendations. And there are resources for healthcare professionals, webinars, CPD courses, and training programs for internationally trained healthcare professionals covering evidence-based medicine and PCC. And of course, the most important slide, we'd like to really acknowledge everyone who's been part of this initiative over the past several months. We truly appreciate everyone's contributions. Specifically, we have the CAN PCC Collaborative and all the groups and the guideline teams. Of course, the members of the public who have been giving us their input throughout, the health organizations, the CCMOH and FPT, and the PHAC PCC Secretariat, and everyone who's provided valuable input throughout this project. Thank you so much. And here you go. Everything can be found. This is one really easy website to remember, canpcc.ca. And here are some of the references used to substantiate some of the data presented today. And with that, I'd like to pass it back to Dr. Morrison.
Thank you so much, Drs. Falcone and Quinn, for that wonderful, thoughtful, informative presentation. I learned a lot, and I particularly enjoy the evidence tables as a nice, concise tool to present the decision-making. We are now going to open the floor for our Q&A session. This is your chance to ask questions and hear directly from our expert speakers. If you haven't already, please go ahead and submit your questions using the Q&A pod. Just before we begin, we kindly ask that questions remain focused on the content of today's presentation. This will help us make the best use of our time and ensure the discussion aligns with the session's objectives. With that, we'll begin our Q&A. Invite your questions for the speakers. I will start with a couple that are already in the Q&A pod. And so Drs. Falcone and Quinn, there seems to be a little bit of a desire to understand the diagnosis or the clinical diagnosis around PCC. And so I remember the slide at the beginning of the presentation speaking about time intervals. But can you comment a little bit about, for example, if particular symptoms must be present, if they can come and go, things like this? And then also, what about symptoms that may be very common symptoms, even in the general population, those without PCC? Recognizing that some of these symptoms may be relatively common even in the absence of PCC.
I'll start if it's okay with you, Dr. Falcone, because I think there's another question that will really speak to your expertise as well, but I'd love to hear your thoughts in response to this as well. I think one of the most important things to remember is we have a clinical case definition, but not a set of diagnostic criteria with a sensitivity and specificity or an accuracy performance. Right? So we conceptualize what we think and understand what post-COVID condition is, but we don't have a series of, do you have, one or more of these things? And this is the diagnostic criteria. So with that said, it leaves us with a challenge to figure out to the question, is this person's shortness of breath due to post-COVID condition? Is it due to another chronic health condition that Dr. Falcone's work has helped us figure out which tests we might do to exclude those? Or is it just common? Fatigue is exceedingly common. I'm tired all the time. My wife is tired every day looking after our 3 kids. I don't think either of us have long COVID, but if I was to be investigated by a physician, it might be challenging to figure out whether that was truly a manifestation. The last thing I'll say before I get Dr. Falcone's take on this is you do not have to have one or any specific symptoms to be classified as post-COVID condition. They have to be in chronological or temporal relation to a suspected or confirmed COVID infection. You don't have to have a positive rapid test or a blood test to prove it. But the symptoms need to come up after that. And ideally, what we do as clinicians is to try to find out, did you have those symptoms before you thought or you knew you were infected? And that can help sort of tease apart that a little bit. But I'd love to hear what Dr. Falcone has to say on this as well.
Yeah, thank you so much. And this is really a subject of a lot of discussion and debate, So certainly, like Dr. Quinn mentioned, there's a careful evaluation of the start of different symptoms. But like he said, a lot of the symptoms can be associated with other comorbidities, which is why, as you see, a lot of the testing that's done, especially in that initial evaluation of individuals with suspected PCC, and possibly also later, because things can change, right? Symptoms can evolve, clinical conditions can evolve. The first thing we do is test to diagnose or rule out other comorbidities that can have symptoms in common with what's associated with PCC. And that's the first step. And you might have heard from some of your patients or other individuals in the community that sometimes these tests come back negative, but the symptoms are there. They're impactful. They're impacting quality of life and functional status. That doesn't mean that there isn't something going on. It means that we gotta work harder at finding other ways of diagnosing those things that are not captured with our current diagnostic tests. And that's where research plays a role. And of course, in an ideal world, we would love to have a blood biomarker that we could measure and that gives us, with some fairly good certainty that there is a diagnosis of PCC. And another point that was mentioned in the question is about the variability, right? And that's another layer of complexity because symptoms can wax and wane over time. And some symptoms can appear all of a sudden way later after the initial infection. But they're suspicious because they tend to be highly associated with PCC. So that's another aspect that needs some careful investigation. And I suspect some of our future longitudinal studies on symptom evolution, now getting at the 5-year mark, might be very revealing to that effect.
Dr. Falcone, I'll say as a clinician, I still struggle when I see a patient to know what tests I should do. And your team did a great job looking at different priority ones. In your expertise, is there still a test that you're stuck with and we weren't able to address in our work, but you're still struggle with whether they should or shouldn't have that test when you're seeing patients? Is there any one or a couple that come to mind?
So you're asking, so tests that, there's a lot of tests that were considered when we were making our list for the recommendations, and it's just because we had a limited number. I would say that, I wonder a lot about the serologies involving other chronic viral infections and their role, because there are mechanistic studies that show something that could be interesting as either being associated or causal in the setting of PCC. So stuff like EBV, CMV, etc. So that's one. As an infectious disease specialist, I do ponder that test a lot, or those tests a lot.
Okay, thank you very, very much for the fulsome answer and discussion. Recognizing the time, I would like to extend our thanks today to Drs. Falcone and Quinn for delivering a great, informative, and engaging presentation. And of course, a sincere thank you to those who joined us today. Your time and active participation are truly appreciated. Before we officially close, I'll just pass it back to our speakers for some final thoughts.
Thanks, Dr. Morrison. I just wanted to thank everybody for taking time out of your busy day to attend, and I hope that what we have done today is deliver some important information to you and help improve the care of our patients or your care if you are a person with lived experience.
I echo Dr. Quinn's sentiments exactly. Thank you so much for your time, for your attention, for your feedback, and I'm sure we'll probably get more feedback once we're offline. So looking forward to reading you.
Okay, great. Thank you so much, doctors. And finally, to our audience, a friendly reminder that you will receive a brief anonymous survey following today's session. We encourage you to take a few moments to complete it, as your feedback is invaluable in helping us strengthen and shape our future programming. So thank you once again, and we wish you a wonderful day.